I'm honored to be with you, and I was once asked to talk about infant mental health and told that I had 7 minutes to do it. And then I have a 2-semester course, so today they asked me to be somewhere in between those two in terms of time, so I'll do my best. When we talk about real estate, we talk about location, location, location as the 3 most important things. When we talk about mental health in young children, it's relationships, relationships, relationships. So just to be clear, when we talk about infant mental health, we're really talking about healthy social and emotional development. Much of what I'm going to tell you has actually been known for quite a long time. Research recently has focused a bit more on neuroscience than it did before, but the child development researchers have demonstrated for a long time that early experiences matter, but a lot of attention began to be paid to this with a sort of luminary report from the Institute of Medicine called From Neurons to Neighborhood, which really was a comprehensive review of child development research and pointed out that there's actually a convergence amongst research in child development, research in neuroscience, and research in economics about not only the importance of early experiences, but also the cost effectiveness of getting children off to a good start. So to make the case about why early experiences matter, I'm going to talk briefly about 3 different things. The first is I'm going to touch on brain development. I'm not going to spend a lot of time on that, but I think it is an important consideration. The second thing is I'm going to make the case that adverse early experiences may have long-term consequences, affecting not only mental health, but also physical health. And finally, I'm going to argue that psychopathology in early childhood is real, impairing, and may be lasting. So, as you know, brain development in young children has gotten increasing amounts of attention, not only in the press, but also in the policy arena as well. And there are a few things that you should know about this. The first thing is that we know that genetics supplies the basic blueprint for brain development, but experiences that the individual child has adjust the genetic plan of the brain and shapes the architecture of its neural circuits. Some circuits are very open to experience, other circuits are less open to experience. But in general, in order for us to adapt and survive as a species, it's important that we have a lot of adaptive capacity in our brain. This serves us well in many ways, but it also means that if we're raised in adverse caregiving environments, those effects will be real and potentially lasting. Circuits that provide basic information tend to get wired earlier than those that process more complex information. Higher circuits build on lower circuits, and skills beget skills. The metaphor for this is a house. If you think about a house, you start with a foundation. Now, if you have a faulty foundation, you can still build a house, you can still take corrective action, you can hire a shoring company, all that stuff, but it's going to cost you a lot of money to do that. If you get the foundation correct, it's much easier to build a house that's going to be lasting and do well. Abnormal input to neural circuits or inadequate input to neural circuits can lead to the development of abnormal brain development or abnormal circuitry. And once a sensitive period for a particular circuit has closed, the effects may be overcome, but in terms of biological energy, it's going to require a lot, and in terms of money, it's going to require a lot to overcome the effects. So if we can get it right to begin with, we're in much better shape biologically and economically. Okay. There's an increasing recognition that adverse early experiences may have very lasting effects. And sort of the classic study in this area you may have heard of, something called the ACE study, Adverse Childhood Experiences Study. This is a collaboration between Kaiser Permanente in San Diego and the Centers for Disease Control. 17,000 adult patients subscribing to this HMO in San Diego. So you have an HMO kind of population. So there's some range of social class, but basically you're lopping off the extremes if you look at people who belong to HMOs. And they're participating in just routine health care. And they filled out a little questionnaire with 10 items on it. These are the 10 items. When you were a young child, did anyone in the family abuse substances? Did your parents get separated or divorced? Did anyone have a mental illness? Was your mother physically abused by your father, or vice versa? Was anyone involved in criminal behavior? Were you psychologically or physically or sexually abused? Were you emotionally or physically neglected? And all they did is tally up a score from 0 to 10. So if you had none of these, it was 0. If you had 1, 2, 3, 4, whatever. And then they've looked at an enormous range of outcomes. For example, if you look at adverse childhood events and adult depression, you see that if you have 5 or more adverse events in early childhood, then you have 5 times the rate of depression as if you have only 1. So a huge, and notice the stepwise increase. Each time you add a risk factor, your risk for this adverse outcome increases. This is also true for alcoholism, for illicit drug use, for suicide. And how about this one? Ischemic heart disease. How about autoimmune diseases, chronic obstructive pulmonary diseases, headaches, liver disease, lung cancer, fetal death, promiscuity, sexually transmitted diseases, teen pregnancy, unintended pregnancy, all have this same kind of linear function with increasing numbers of adverse experiences, increasing likelihood of these adverse outcomes. That's not to argue that it's causative. It's to argue that the probability that the individual will develop this adverse outcome is increased. Here you see a pyramid from the CDC where adverse childhood experiences occur first. These are believed to impair social, emotional, and cognitive functioning in the individual, and there's very good evidence for that. That is hypothesized to lead to the adoption of risky health behaviors in which the person places themselves at risk in a variety of ways, which then leads to disease, disability, and social problems, and potentially to early premature death. Okay, so what about psychopathology in young kids? Many of us are uncomfortable with the idea of talking about psychopathology and infants or toddlers or very young children in the same breath. If I say baby to you, what comes to your mind? You have this image in your head of a plump, happy, delightful baby. Babies elicit feelings of promise of the future. People who haven't been affected by adverse experiences. And yet, many young children in Baton Rouge and New Orleans, in the United States and in the world, experience extremes of adversity that place them at risk. In this part of the procedure, Devin is supposed to put a puzzle together. And the puzzle's a little bit too hard for him to complete himself. And so we look at how he and his dad navigate the task of putting the puzzle together. So I'm going to ask you to stipulate that Devin is a very aggressive little boy. If this is representative of his behavior, then he's got very high levels of aggression. This is a study of 1,300 children followed over time from age 2 serially through age 9 years. What you see in this top line, this is a cluster of kids who, when they were 2 years old, had extremely high levels of aggression. Then the next 2 lines are kids who were in the moderate range of aggression, and the lower 2 lines were clusters of kids who had very low levels of aggression. So what do you see? In the 30% of kids in the moderate to high aggression, there are 2 moderate groups, one of which declines over time, another of which declines a little bit over time. But in the group at the highest level, the children who are most aggressive at age 2, absent any intervention, remain extremely aggressive at age 9. And the consequences of those aggressive behaviors are considerable. This is Walter Gilliam's work, in which he pointed out that pre-K students are expelled at a rate 3 times higher than their K through 12 peers. And if they're in private preschool, it's 13 times higher. So imagine the effect of a young child who begins his scholastic career with getting expelled multiple times from preschools. He's already on a trajectory that's headed for trouble. A number of children who have aggressive behavior are children who've experienced traumatic experiences of a variety of types. There's been some work done by a colleague of mine at Tulane basically mapping out what post-traumatic stress disorder looks like in very young children. And it turns out the same cluster of symptoms of post-traumatic stress disorder that are evident in young kids, that are evident in adults, are also evident in young children. That is, they repeatedly and involuntarily re-experience the trauma through remembering it. They experience an emotional dampening down of their responsiveness. Their central nervous system becomes hyper-aroused, and they're irritable, they have difficulty concentrating, their sleep is interrupted. The way that the symptoms manifest are different, but the core of the symptoms is very similar. And I'm talking about kids as young as 12 months of age who are exposed to very extreme forms of trauma. Here's a study from the group at Tulane in which we're following a group of kids who were traumatized, who had met full criteria for PTSD, that's the top line that you see, and a group of kids who were symptomatic with PTSD but didn't meet full criteria. These kids are followed over time. Now, this is not an intervention study. This was just a following children over time, but they're initially seen at an average of 4 months after the traumatic event. Then they're seen at 16 months after the traumatic event and at 28 months after the traumatic event. There is no decrease in their symptomatology over time. A third of these kids were receiving treatment in the community. So despite the fact that a third of the kids are getting treated, they're remaining symptomatic over time, probably because there are specialized evidence-based treatments for PTSD that are far more effective than business-as-usual treatment. This is a study conducted by my colleague Helen Egger at Duke University, recruiting young children between the ages of 2 years old and 5 years old from community pediatric clinics in Durham. And what she found is that the prevalence of diagnosable psychiatric disorders in children between the ages of 2 and 5 years are roughly comparable to what we see in school-age kids, in adolescents, and in adults. So what are we going to do about this? As I said, relationships, relationships, relationships. The most important active ingredient in early experiences is the caregiving relationship that the young child has with one or a relatively small number of caregiving adults. We know from animal work through human work that nurturing and responsive relationships can build healthy brain architecture, and that in turn can set the foundation for future adaptive behavior. We also know through a number of studies that healthy relationships with caregivers buffer the child and protect the child when they're in high-risk environments. And when protective relationships are not available or not provided to the child, then the child becomes headed for a more problematic developmental trajectory. So we know what sort of outcomes we're interested in kids. We want them to be physically and psychologically safe. We'd like them to be securely attached and trusting. We want them to be socially competent and able to navigate the world of peers and adult relationships outside of the family. And we want them to be able to regulate their emotions well. We also know, through careful research, the kinds of parenting behaviors that drive those outcomes. Sensitive caregiving, knowing and valuing the child as an individual, and being able to place the needs of the child ahead of one's own needs. That's really the essence of parenting, isn't it? being able to recognize and provide what the child needs and set your own needs aside. What that requires is psychological and investment and commitment on the part of parents. Because it's through the primary caregiving relationship that environmental risk conditions are transmitted to the baby. We know, for example, if you look at developmental research, that children who are poor, economically disadvantaged, are at dramatically increased risk for a variety of adverse outcomes. What does it mean to a 6-month-old infant to be poor? It means nothing except as the child experiences poverty through the primary caregiving relationship with the caregiver. If that caregiver is able to provide a safe and secure relationship for the child, then that child's developmental trajectory is going to be very different from other kids who don't get that kind of relationship. We also know, if you look at various biological risk factors in the kids, and I'll just give you one example, there's a particular temperamental type called behavioral inhibition, which is essentially an extreme form of shyness, which can be detected, the precursors of which can be detected as early as 4 months of age. Those kids are at dramatically increased risk for serious anxiety problems in school-age adolescence and beyond. When the mothers of those kids, as young as age 4, are able to supportively but insistently nudge the kids into social situations to face their fears, to cope in a tolerable way, those kids are far less likely to develop serious anxiety problems. So this biological risk factor of a particular temperamental type, its effects are reduced through the quality of the relationship that the young child has. Now I want to show you 3 different kids here. His mom comes in, and what does he do? He says, "Mom, it was terrible. I was all alone. I missed you. It was horrible." He reaches for her as he approaches her, gets picked up, nestles in, and within 10 seconds, he has resolved his distress and feels convincingly better. Why? The reason is because he knows that when he needs someone, Mom is there for him. And he begins to think of himself as someone who belongs to a loving relationship in which someone cares for him, so he must be pretty special. So let's think about him as we watch this next little girl. She's 15 months old, but it's the same situation. She's in the room. We've asked her mom to leave. She's very distressed. There's a stranger there with her. We see a little girl who becomes very distressed, again, induced by this separation. Her mother comes in, and she's unable to use her mother to make herself feel better. Now, her mother is not just her primary caregiver, she's her only caregiver. So what is the rule in her head about what happens when you really, really need someone? There's no one there. No one can make you feel better. Now, 2 things that you couldn't hear. The first is when the mom came in and saw her daughter crying, her 15-month-old, she said to the stranger, "Now you see what I go through every time I leave the room." What does that mean? What that means is that the intensity of her own needs is so great that she can't even feel for her baby who's distressed and alone and has no way of understanding why this separation even happened. The second thing is when the little girl goes over and flings herself down and bangs her head with this thud on the carpet. I don't know if you heard that. She says, "I hate when she does that." What does that mean? This is not something we've induced with our little procedure here. This is how this dance between these 2 works. So I've shown you a very healthy relationship. I've shown you a very unhealthy relationship. Now I'm going to show you the absence of a relationship. This is a little girl in playtime who is in St. Catherine's in Bucharest, Romania. It's outside playtime. We see a little girl who's very distressed. For a long period of time, no one responds to her at all. I think the caregiver thinks she's distracting her or something. And then when the caregiver goes to pick her up, you can see that it does no good because she hasn't learned that when she's distressed, another human being can provide her with comfort. And that's because what young children learn is that not everyone is to go to for comfort. There's a small number of people that are your go-to people. Think about little Antoine. Antoine knows his go-to person is not this stranger to his left who he's only met 20 minutes ago. His go-to person is that lady who comes in the door. That's mom, and that's who I'm going to. This little girl doesn't have a mom, doesn't have that person to go to. And the consequences of that are enormous. We tried to do intellectual testing in this little girl, and she got the lowest score possible on the Bailey exam. It's just a test of infant development. Below 50, it's the lowest thing you can get. Now, whether that's because her cognitive development is so impaired or because she is socially so impaired that she can't even engage in test taking, I can't answer that. But either way, it's trouble with a capital T. This is a study of over 1,000 kids around the United States. For those of you interested in school readiness, these numbers here are statistical effect sizes. So we're looking at the statistical effect size of parenting on school readiness. I'm just going to call your attention to that first one. 0.89 is an enormous effect size. In statistical terms, that's a very large effect size. So if you want to talk about school readiness, talk about the quality of the relationship that the young child has with his or her parents. And we looked at psychiatric disorders in our Romanian kids. They're 4.5 years old. 4.5 years old. We interview their caregivers in detail. And what we found is an enormous number of these kids have very serious psychiatric disorders at the age of 4.5. The care as usual group are kids who had more prolonged institutional care. You can see the majority of them had psychopathology. The kids that we removed from the institutions and placed in foster families at an average of 22 months of age have very high levels but significantly fewer than the kids in the institutions. And the never institutionalized group is just typically developing Romanian children. So I make that point only to say that there are lots of serious psychiatric problems in these very young kids. Now, what we found was, if we looked at the quality of caregiving that the children received when they were 30 months of age, whether they're in foster homes, whether they're in adoptive homes, whether they've been returned to their parents, or whether they're in foster care, wherever they are, we just do observations and carefully code the videotape behaviors, and we come up with a measure of caregiving quality. That is predictive. 30 months of age, the caregiving that they're receiving is predictive of signs of very serious psychopathology that you can barely see in the other box over there. Just take my word for it. It's not good stuff. So what we're interested in is, what's the role of security of attachment in mediating this relationship? So there's a direct path between caregiving quality and psychopathology 2 years later. What we find is that caregiving quality is predictive of security of attachment is predictive of psychopathology, and we plug in security of attachment, the relationship between caregiving quality and psychopathology goes away. So all of that just means that the reason the children have reductions in psychopathology, or the degree to which they have reductions in psychopathology, is related to the degree to which they form secure attachments to whoever's caring for them. Okay, so let's return to our little girl. We saw her at 22 months. She was assessed, she was randomized, placed in foster care. Here she is interacting with her foster parents. This is 8 months after we saw her outside in the institutional playground. Here she is in her foster home interacting with her foster parents. So here we see her 8 months later. She's enormously better socially, much more positive in her emotional presence, obviously the apple of her foster mother's eye, playing delightedly with her, but she's 30 months of age, and we hear no expressive language. All we hear are these little squeals. So the next follow-up age is 42 months. So now at 42 months, she's been in this home for 20 months, and here she is with her foster mother. I'll tell you what's going on because it's especially hard to see that. Hope it'll get a little better when I turn it on. But she's sitting here with a teddy bear, and she's putting a vest on the teddy bear, and she's practicing tying knots with the vest. Her foster mother's in the background talking to her. There's also a television set on that she occasionally glances at. What happens is, after they talk for a little bit, she begins to make up a story about the teddy bear. The teddy bear is going to go to school. He's got to put his slippers on. Apparently, the Romanian word for slippers sounds very much like the Romanian word for potato. So she says he's got to put his potatoes on and go to school. And her foster mother says, wait a minute, potatoes? She says, no, not potatoes, slippers. Anyway, the point is, she is constructing an imagined scenario and sharing it with her mother, which is exactly what we want kids at the age of 3.5 to be doing. Now, think about the developmental trajectory, because we don't want to just think about where kids are now. We want to think about where they come from and where they headed in particular. Think about the developmental trajectory that she's on now, and think about the developmental trajectory that she was on at 22 months of age. Very, very different trajectories.